Well, thanks for coming. This is our second in a quarterly series of brown bags that we're doing this year. And after the one that I did, which was talking about the future of academic medical centers in a reformed healthcare environment, we started talking, a lot of the questions had to do about health reform and the health exchanges that were being set up, and were we prepared for them, and what were we doing? I talked to Becky Korinick, who's our Vice President for Clinical Contracting Strategies, and she said that she would be happy to do something that was a little bit more detail around that and some more specifics about what do they mean, and now we can say what are we seeing, and then talk about how we were positioning UTMB to be able to respond to this sort of new environment. And so Becky's worked hard to give us, I think, what is a really good overview. I had an opportunity to review it with her, and I think that this will be a really good presentation. They're meant to be interactive, so if you feel like asking her something as she's going through, please feel free to do that. If you're a little bit shy about what looks like interrupting people, my mother was always big on don't interrupt, you could hold them till the end and we have an opportunity for questions then as well. But without further delay, I'd like to welcome Becky to come talk to us about the health insurance marketplace.
This is going to be an informal conversation, so please stop, ask questions. If you don't understand something, speak up. It's a bit of a complicated topic, and so I'm going to try to do a high level. Again, detailed questions, feel free to ask them, and if it's too long of an answer, I'll put it off till the end. But again, let's see how much of this we can work our way through. For most people, I think this is what comes to mind when you talk about healthcare reform and the Affordable Care Act. Confusing, what is it? What does it mean? How do all the pieces link together? So in order to understand the health insurance marketplace, we first have to talk a little bit about the Affordable Care Act. So that's where we're going to start. These are the different pieces we're going to cover. Number of people that were originally intended to pick up coverage through the exchanges, how people actually enroll, what we're doing as an organization to participate, and then with regard to concerns, we're going to talk a little bit about what's going on today post October the 1st when the rollout happened. You can't read a newspaper or turn on a TV without hearing some information about that. So with regard to the Affordable Care Act, this was signed in March of 2010. So the critical pieces: expanding health coverage to more people, providing greater benefits and coverage, including more preventive services. So very specifically here, oftentimes people, they might have insurance coverage, but for example, they might not have prenatal or maternity benefits. Preventive care historically has not been covered for a number of services. So this was added via the Affordable Care Act. Again, the major issue is more affordable coverage to individuals across the country, therefore hoping to insure more people with less insured and less of an unfunded population. How does the new law affect UTMB? Well, certainly by decreasing the financial barriers for individuals who don't have coverage. That's a goal. If more people are able to pick up coverage, that's less of those who don't have the money or who have financial issues. We do have, though, potential challenges. As more people are covered, it creates potentially more obstacles or different types of challenges for us to deliver the right care in the right place and at the right time. And then finally, certainly it allows the institution, by contracting with these different companies that are offering products on the health insurance exchange, more individuals to have access to our providers, our facilities, and our services. There is a bit of confusion. What is the health insurance exchange versus the health insurance marketplace? Originally, the title was the health insurance exchange. So for short, people call it the exchanges. Back in early 2013, the federal government decided health insurance exchange wasn't really a great name and didn't clearly determine or identify what it meant. So it changed to the health insurance marketplace. Again, I'm not sure that provided a whole lot of clarity either, but that's exactly what occurred. So with regard to the critical components of the law, guaranteed coverage for individuals with pre-existing conditions. Historically, people could have been denied coverage based on their current health status or their current long-term or chronic health condition. A specific point to note is the federal cost assistance to those who are eligible to help pay for their health insurance premiums. So individuals who meet a certain threshold, and we'll talk about that in detail here, they're eligible for federal subsidies. And then finally, and this has also gotten quite a bit of political commentary, it requires most Americans to have health insurance or they will become subject to a financial penalty. So we'll talk about that detail as well. So with the Affordable Care Act, and I want you to look at the dates, July 2012 and May 2013. And that's critical because if when we get to the end of the presentation, we'll talk about some of the numbers and things that are going on today, and they look drastically different than what's on this slide. But this is a bit of a complicating slide, so I'm actually going to read it from the bottom up. But with the original presentation and passing of the Affordable Care Act with the health insurance exchanges to go live, the original thought that 14 million people would gain access to coverage in 2014. That was 7 million who would be covered by Medicaid and CHIP because of the Medicaid expansion that has occurred throughout the United States. Not within Texas and several other states, but other states in the country did agree and did choose to expand Medicaid. The exchanges would offer insurance or coverage to 9 million people. And then the negative potential here is 1 million individuals who are today covered by their employer would potentially lose coverage based on a small group employer deciding to drop coverage, or potentially a large group or other employer deciding to change the number of hours required for an individual to be full-time employee or to gain benefits. But again, very conservative numbers, down 1 million, and then non-group and other would be individuals who had individual or family policies, and their coverage might be changed. But again, a net gain of 14 million with a potential decrease of only 2 million in the employer and non-group categories. In 2023, you see that change to 25 million, meaning expecting 25 million more people than today having coverage on the exchange. With the exchange going live, when all of this was agreed to and approved back in March of 2010, an estimated 46 million people in the United States without health insurance coverage. So when you think about increasing it by 14 million one year and 25 million several years from now, you begin to see that we're closing in on that gap of what historically had been 46 million. But again, as you look at what's happening today, and we'll talk about that, those numbers look a bit different. What is the health insurance marketplace? There's a lot going on in this slide, so let me try to explain it for you. Really, it's an online shopping network. That's the best way to explain the health insurance exchange. Here we go. We have the individuals who are looking to potentially purchase. We have the small group employers. And again, the perspective is that small groups don't today get penalized for not offering health insurance. But again, the thought would be by purchasing insurance on the exchange and helping their employees purchase insurance on the exchange, it would be more affordable and more readily available. But as individuals walk up the line, you see they have to be eligible first. So their eligibility is determined. And there are a number of different ways that that's being done. First, then you go to the employer-based insurance. If the individual has insurance, affordable insurance through their employer, they're not eligible to purchase anything on the exchange. They can try to do it, but ultimately what's going to happen is the employer is going to get a fine. So it's going to loop back around to the employer once that occurs. Again, that's assuming it can all be tracked. I'll just offer that comment. The public subsidy options, again, individuals between 133% and 400% of the federal poverty level may qualify for public subsidies. So that would also be part of this qualification process. And then individuals who would qualify for CHIP or Medicaid. And again, moving forward after hitting all these different components, they're available then to look at the different plans and the different options and start selecting the type of coverage. So what is the marketplace? Well, it's the famous www.healthcare.gov. That would be what truly is the marketplace and where people go to sign up. It's an online shopping network. The intent is for people to compare and purchase health insurance coverage that becomes effective on January the 1st, 2014. Open enrollment began October the 1st. And again, this is when we all learned what works and what doesn't work relative to the website and the exchange. Extends through March 31 of 2014. Originally, open enrollment was just going to extend through December 31st of 2013 with coverage January the 1st. It's already been extended to March 31st. There's a high likelihood it will be extended even further than that as time moves forward, depending on the availability of the website and the exchange and what people can access. Federal subsidies. Again, 133% to 400% of the federal poverty level. I'll show you some numbers in just a minute so you can see better what that looks like. And then the benefit plans available. There are 4 different benefit plans that are categorized by a metallic color: bronze, silver, gold, and platinum. There's also a catastrophic option for young adults. So that's the 5th option that's available. But the primary color options are the metals. And those benefits, those plan designs, are done based on the eligible component for the deductible and the co-insurance. So an individual with the bronze plan might have a 60% co-insurance and a $5,000 deductible. A silver plan would be 70% co-insurance, and it could be a $5,000 deductible or a $3,000 deductible. The gold plan is an 80% co-insurance, again, $3,000, $2,000 deductible, and then the platinum plan is 90% co-insurance. So just like with our benefits today through UTMB, we have a co-insurance component. We would probably be in the gold category at the 80%, but the different levels here have to do with the deductible as well and the amount that the individual has to pay for the co-insurance. So what does healthcare.gov look like? If you were able to log on, this is the picture you would see. This picture has actually changed a bit since October the 1st. At the bottom, you see the comment that says, see plans and prices in your area. Originally, you couldn't log into the marketplace and see the plan pricing information. You had to go in, put in all your information, specifically your age, and then you could look at the rates and the different benefit plans that were available. This has actually been changed. The difference is if you want to see the plans in your area and you hit that button, assuming it works, you decide if you're looking for an individual or a family, and then you're either 49 or over or you're 49 or under. And so the reason why I point that out is it's very misleading because the rates are actually done based on an age rated scale. So you might be 30, but when it says 49 and under is the preliminary rate you're going to look at, it's probably going to be drastically different than the rate that you would see if you were 30 years old. So, but this is what doesn't work right now on a regular basis. This slide here, it's a lot of data. I'm going to try to walk you through just high-level information. On the far left-hand side are the federal poverty levels. So people often say, well, actually, what is that? What are those dollar amounts? 133% of the poverty level is $15,300. 400% is $45,000, almost $600. So we've got individuals who have different income levels, and they're eligible for different amounts of subsidy. So for the individuals at 133% of the poverty level, they're actually eligible for the greatest amount of subsidy or premium tax credit. And if you look at the $15,000, $282, 2% of their income, the annual premium in this particular arrangement is $2,700. The government would pay almost $2,400, leaving the individual to pay about $25 a month. And this is for a benefit plan that's 70% co-insurance with a deductible of $4,000. So again, the other piece you have to think about is the individual who's at 133% of the poverty level also coming up with the funds to cover that 30% co-insurance as well as the $4,000 deductible. And I've used this example as well. It's the family chart, the same component. And again, the very last line of both charts, the last two lines show 9.5% of income. The federal government decided that affordable health insurance is based on 9.5% of an individual's income. So that's where that 9.5% comes from. It's all tied back into the way the employer funds it, how that's determined, and then what the federal government will subsidize with regard to the premium tax credit. The other comment that I will make related to this data, there are also subsidies provided to individuals to help them meet their co-insurance and their deductible. Individuals have to be qualified for that. They are only offering subsidies for individuals who select silver plans. So that's not widely known. That's a detail, but for those who understand the information, when they log on to healthcare.gov, that's an important fact. What are the payers doing in the area? This should help provide some information. First of all, let me comment on the state of Texas as a federally facilitated state. So what that means is it's the federal government who is dictating and monitoring what happens with the health insurance exchange or the marketplace in the state of Texas. The federal government is managing the marketplaces in 27 states. There are another 7 states who have a partnering arrangement with the federal government. So the government might be managing the website and the state's Department of Insurance is managing the exchange. For the state of Texas, it's all being handled presently by the federal government through the Centers for Medicaid and Medicare Services through CMS. For the different payers in the marketplace, Harris, Fort Bend, and Montgomery counties, you can see the different plan names. Galveston County, it's Blue Cross, Cigna, and Community Health Choice. Jefferson and Orange counties, Blue Cross, Cigna, Community Health Choice, Molina. And then finally, the only plan that's opted to cover the entire state of Texas is Blue Cross. So again, that's a pretty powerful statement on Blue Cross's part and what they had to go through in order to be qualified to provide services throughout the state of Texas.
Becky, you might want to comment on United's absence in that.
Yeah, I will, thank you for that. United is absent. United made a decision not to participate in any federally facilitated programs around the United States. So they are participating, but they're participating in the state-run exchanges. So a much smaller list of states that United is present in. Another comment here with regard to Aetna, Cigna, Blue Cross, Humana. They are really going after the small group market. So for small group employers today that do not offer coverage, their intent is to pick up a number of the potential uninsureds today through their small group offerings. Each of those plans have a very strong small group book of business, and so they are looking to grow that book of business. The area statistics, different people have asked me, what does the marketplace look like in our area relative to eligibles for the exchange? And so I've highlighted this based on different counties. You can certainly see Galveston County, but more specifically from a greater Houston-Galveston region, what would the payers be looking at to determine whether or not they wanted to enter into this book of business? And so almost 1.5 million of currently uninsured. You have a number of the Medicaid players. Molina is on the prior page, Community Health Choice. They're going after this book of business to look at potentially picking up parents of what they call today their CHIP enrollees. So that's an opportunity for them to potentially grow their business in this market. Who's eligible to participate in the exchange and how does it work? Individuals will pick a plan based on where they live or work. Unlike Medicaid, there is no month-to-month eligibility. This is a critical piece for us as providers to understand. We are very accustomed, particularly in this institution, to working with our financial counselors and working to qualify individuals for Medicaid so that then they potentially have coverage for their recent diagnosis or what their illness might be and to have funded access to services. The exchange does not work that way. So after March 31st, the enrollment period, as it has been stated thus far, will be over, and individuals will not be able to even apply to get onto the exchange unless there's a qualifying event. And so a qualifying event is the same as it would be in our situation. Today they've got to have a divorce, they recently lost their job. That would be a situation if that prior divorce, that their spouse was how they accessed their health care insurance, then that would be considered a qualifying event. This comment about individuals who have access to affordable coverage, again, the government assigns access, and affordable is 9.5% of an individual's income. So just to be clear there. What are we doing as an institution to participate on the exchange? We actually have contracts with Blue Cross, Cigna, and Community Health Choice. Each one of them, from our perspective as a provider, represented a different strategy and a different focus. And not only were these the only plans that are in this market presently, but who we participated with gave them then the option to go qualify. If we were not in their product, they would have a hard time being qualified by the federal government to offer a product in Galveston County. One of the things that we had to think about, for example, Blue Cross. We cover a large book of business today in Blue Cross that aren't our own employees. It's other individuals who come see us. We might get paid one way for that book of business, but then those patients come to us on the exchange. The exchange wanted rock bottom rates. They expected, from a provider's perspective, we were supposed to offer much lower rates to them. What we didn't want to do was see business that came to us at a much higher reimbursement come to us over here at a much lower reimbursement, and us not be prepared for the changes or any of the other opportunities or challenges that come with that. Again, for individuals who are able to pick up coverage on the exchange, it does make our services available to those individuals. So today, people who may not be able to come see us due to a financial barrier, certainly with our participation in these products, it allows us to make our services available. The other thing that our financial counselors have done is sought certification as an application coordinator for through CMS. And I look back at Nancy Polk and she kind of is laughing. And the reason is because they made this grand plan. They worked out appointments with individuals to come and sit and for us to help them apply, and the website didn't work. And so they've tried scheduling these things numerous times over the last several weeks just to find that they've not been able to log in. But we do have a process here to work with individuals to help enroll them. We've also talked with the students about training them as well. That's all being done through Ruben Escamilla's area. There's some phone numbers here. But again, we are working to do what we can to help individuals get more information and then be qualified to have coverage through the exchange. So, what's all the fuss about? Again, I think this is what's happening every day on the news, on the newspaper, and what are people talking about and why are they talking about it? So the first piece I think we see is that we've had huge issues with the website. So to start with, that's where we'll begin our conversations. The website doesn't work. As of Monday of this week, it's a projected 5 million people will have received cancellation notices. Well, if you remember in one of the other earlier slides, we were talking about potentially 1 million people that might have received cancellation notices. So we're at 5 million now. Based on the projections, I think that number is likely to grow significantly before the end of the year. Why are they being canceled? Again, these are primarily individual or family policies that people have directly with their insurance carrier. And many of those benefits, or what is being offered, is not consistent with the benefit requirements that are required under the Affordable Care Act. The other comment is these insurance companies are often offering different alternative plan designs, but it's not what the individuals want, and the premium rates are significantly more expensive.
As part of this, also the insurance companies trying to broaden the risk pools a little bit by taking these individuals and put them into larger groups from a risk perspective,
I think the answer is I don't know. Looking at it from an insurance person's just looking at it from what I would want to comment on from an insurance perspective, I think that it was a risky play to make if that was really their goal at this point in the process. I think some of them would have tried to hang on to those people if they could, because we'll talk about it in just a minute. It's actually more expensive to try to move a Blue Cross person from one side over to the exchange. And so I don't think that would have been their play had they been able to control all these pieces. I mean, an easy question to ask, once the website is up, will it be able to handle the additional traffic? I think the original numbers for the website was originally set up to accommodate 11,000 plus people a day. So I don't really know how we were going to get to the 14 million number at 11,000 a day, but nonetheless.
Becky, also, I heard this morning, and I don't know if it's included in your 5 million number, that Blue Cross is getting, either just did or is getting ready to issue another notices to another 1 million people in California that they're canceling their plans.
Those numbers, that was not in, and again,
That just came out this
yes,
morning.
and again, I think the numbers between now and the end of the year, today it's 5 million, maybe 6 million with the number Donna just mentioned is going to continue to grow.
And it was just interesting to me because I kind of did the math thinking, okay, if 6 million people have lost and 50,000 have signed up, for every person who signed up, there's 6,050 people who lost it.
Right, yes, and which points to this other issue being the death spiral, which it doesn't make sense. Critically, we've got more people signing up and qualifying for Medicaid than what people had intended. I'm not sure why that process wasn't factored in, but with the Medicaid expansion around the country, we've got more people who've opted into Medicaid thus far. And that number, I think right now, is around 3 million is what they're saying. But that's just based on what they know. I don't know that that's a hard number. Individuals with long-term medical conditions are those right now who are making it a point to spend time trying to access the website or find other ways to get in. And why would that be? They have to have the coverage. Unfortunately, they've got to have it, which is what we're going to see potentially as a death spiral here. We've got too many people who have to have the coverage because they have healthcare needs that need to be met, and we don't have enough healthy people, young specifically, that are purchasing the products. Therefore, we're going to see what the insurance industry refers to as a death spiral. Individuals who select coverage to the marketplace may or may not be able to access their same hospital or physician. This is critical, and it's critical particularly for people who have long-term or chronic conditions. If they were thinking that by moving to the exchange, this healthcare provider would be available to them. And we'll talk a little bit about what's happening in Texas as well. The premium rates are higher than what people expected. Again, it's just a fact, they're higher. I think also people see the premium rate and not understanding the significant deductible and co-insurance that goes with that. So the premium rate itself might be what people would consider to be affordable, but when you add the personal out-of-pocket expense that has to be tacked onto that, again, it's a much higher number than what people expected. And then the final piece, individuals are being asked to pay additional taxes. And I'll use a Blue Cross example. In the state of Texas, Blue Cross is reissuing their policies, their individual policies. They've not canceled them, but they're telling people you can have your current product, you can move to the exchange. Happy to keep your current product, but you're going to have these additional taxes. And some of those taxes are to cover the reinsurance for the individuals on the exchange. So the private carriers are also being taxed with the additional dollars that are going to be needed to ultimately fund the activity. So what's happening in Texas specifically? Texas has not seen yet the large number of widespread cancellations that have gone on around the country. Not that we won't see them, but we have had some, but it's not widespread. Several years ago, the governor who was in place at the time was Bush, and he mandated that some very specific insurance provisions be included under fully insured products under the state of Texas Department of Insurance. So there were no more opportunities to offer these very limited benefits if they were being provided on a fully insured basis. So people didn't like it then. The insurance companies yelled and screamed then because of the high cost Today, it actually puts the people in the state of Texas who have these individual policies in a little bit better situation. Again, their policies are going up. Don't misunderstand me. There are increases. Those increases are primarily due to the additional taxes that are being levied, not the issue of higher benefit levels. The individuals, again, this comment about hospitals and physicians, will they have access to them? I don't know if you've heard in the news recently in Texas, but lots of comments about physicians calling the different insurance plans and the insurance company not being able to say whether they're in the product for the exchange or not in the product for the exchange. There's a significant amount of confusion among the payer community related to their own network that's being offered for the exchange. Blue Cross has a different network for the exchange than what they offer in their traditional PPO product. Community Health Choice has a different network than what they can typically offer in their Medicaid product. That's been the same with Aetna, the same with Humana, Molina, Cigna. And again, they're all trying to offer what they consider to be a lower cost provider network. So again, it's difficult to know on the front end from an individual's perspective whether or not their physician or hospital is being included. They can go look, they can make phone calls, but unfortunately there's inconsistent information that's being provided, so it makes it very difficult. Certainly the premium rates are higher in some markets than expected around Texas. We talked about the taxes. Blue Cross is the only payer covering all of Texas. Again, their perspective at some point, if there's going to be a single payer system, they want to be the single payer. So Blue Cross in Texas is part of a couple of other Blue Cross initiatives around the country. There's actually 7 states that are part of the Blue Cross of Texas family. It's really Blue Cross of Illinois. And again, their perspective is to do what they can to command that market. The other thing that Blue Cross of Texas did, or Blue Cross of Illinois, they have their own website. So when healthcare.gov went down, it didn't preclude them from being able to sign up individuals on the exchange. So smart thinking on their part. You weren't able to go in and qualify and look at different plan options. You had to pick a Blue Cross plan. But again, that was their marketing strategy. Blue Cross also offers the lowest premiums for the bronze and silver plans. So the 2 lowest cost plans are bronze and silver, and then Blue Cross offers the lowest prices among those benefit plans. So again, what they can do to capitalize and capture the market is where they're headed. Critical dates, open enrollment started October the 1st. Again, we all know how that's gone. Through March the 31st, my prediction is that will get extended. We don't know yet to what extent, but I think that date will not be a hard date. The other thing that's come out is individuals who want to access the marketplace try to miss a penalty by not having coverage. Right now, it's been said that through the legislative sites, if an individual has gone in and applied for coverage as of March 31st, at least started the application, they won't be subject to the potential penalty. So that's another issue that's out there. November, December is an institution and organization. We're working to do in-services with the different payers to figure out what their requirements for us will be with these new products. Thus far, we've had 3 on the schedule. We've had to reschedule because the payers haven't been ready yet to provide the information they need. So the point I'll make to that is it's going to take some patience and some maneuvering on our part to figure out exactly what this new environment will be. One comment that I'll make is individuals on the exchange have a 90-day grace period to pay their premium. Well, typically in the state of Texas, that's a 30-day grace period to pay their premium. So when we're doing insurance benefit verification, we're going to have to figure out if the individual is current on their premium or not. And if they're not, we're going to have to decide how we're going to handle the situation. So again, complexity on all sides of this process. January 1st is the earliest date for plan participation, and it's, again, the federal government has said if you apply by December 15th, you can be covered by January the 1st. And then finally, as of right now, the closed date for open enrollment is March 31st. So that's where we are. Any questions I can answer?
I just wanted to say.
Hold your questions.
I'm with Financial Counseling, and we are doing paper applications for patients. We're bringing them into the
Thank you.
office and we're filling it out on paper and sending it in to them so at least they can be enrolled and let them hear back from them on what they're eligible for. We're doing a whole lot of phone consultations with people. We're giving them the phone number where they can call and apply online. Apply with the exchange so they can do it online. So if you know anyone that needs help, please have them call us. We can help them in many ways.
It's interesting. I've been asked in a number of places I've been around the Houston area, they'll see information about UTMB being designated as a CAC. Well, there's also navigators that are helping people enroll, which is a different type of an arrangement and a different type of individual and certification. But many hospitals around the area did not immediately seek the certified application coordinator activity, and we did it because, again, if we can provide services to more people and make ourselves more available, then certainly that's what we want to do. So it was a huge opportunity for us, and I applaud Ruben's staff and Nancy and the crowd for going to do that because, as Nancy said earlier, there was no training. They couldn't go in the day before the website opened and be trained somewhere. It was just be ready and be willing to help, which is what's occurred. Other questions?
Could
Go
I
ahead.
ask
Sure.
you to go into a little more depth on the reports of cancellations of individual policies and exorbitantly higher rates being charged for a new policy for these people? The original comments by the people defending the government were saying, well, these are all just really bad plans, and the reason it costs so much more is because the original plan just didn't have much coverage. And then there have been anecdotal reports. ProPublica did one in-depth report on a family that had a Kaiser plan that was like being reoffered to them at double the rate, and it appeared like originally it was a pretty darn good plan. So one explanation is that the insurance market is, for an idiot like me who doesn't know insurance at all, possibility one, somehow the actuarial thing is just being dramatically recalculated. Possibility number two, this is blatant price gouging. Possibility number three, something else is going on that I don't understand. Do you have any further comments on helping understand these news reports and what they signify or don't?
I think that one comment I'll make, just to start with, is the definition of essential healthcare benefits is what is being required for all of the carriers to provide. And so what those benefits are relative to an individual's policy prior to the requirement of an essential healthcare benefit. Maternity is an expensive piece to add to a benefit. Mental health is an expensive piece to add to a benefit. Hospital stay without a cap is an expensive piece to add to a benefit. So again, is there some of this gouging going on in the process? I'm not sure that I could stand here and say absolutely not. I'm not sure who could stand up and say that. However, I do think that when you look at the number of individuals who are potentially or being receiving those cancellation notices and the options that they are being provided to pick up additional coverage, just with some of the anecdotal information and then non-anecdotal. Again, when you see going from a 90% benefit level to a 70% benefit level, but you see the cost increase by sometimes $100, $150, $200 a month, it does become overwhelming. And I also think many at this point are safeguarding themselves based on the fact that we've not to date seen the younger, healthier population pick it up. And I think many people knew on the front end that with a $95 penalty, which is presently on the table for individuals who don't have coverage or some very small percent of their income is the cap for the moment, spend $95 for the penalty or spend a few $1,000s for health insurance. I think for a number of people who fall within the 100 to 400% of the poverty level, that's an easy decision to make. Unfortunately, it's those who have to have the coverage who are picking up the coverage. Other questions?
So Becky, do we know out-of-network benefits, so if we have a Molina enrollee is in Galveston, gets injured or whatever, and becomes UTB, do we know how we're going to get paid for those types of people?
Bulk of them are PPO activity. Not all of them, but the bulk of it is. But again, if they come here and get hurt, it's going to be the same as it would be in the HMO environment. They're going to have to pay for the emergency service. The elective activity may be a different conversation.
And deductible for the emergency service.
Well, The emergency benefit may or may not be subject to a deductible. Typically, an emergency visit is not necessarily subject to a deductible. However, I think the piece that we're going to have to work our way through is not just whether or not an individual has paid their premium. I think also we're going to have to look at, from a self-pay perspective, what are we going to have still in our receivables based on these larger individual personal responsibilities for the deductible and the coinsurance. Because the out-of-pocket maximum, they're very high. They're $12,000, $15,000. So again, more people potentially will have funding for their health insurance. However, we have a different element of the process to evaluate. Other questions? Yes.
Do we have any idea how the Blue Cross Marketplace product will pay the hospital? Are we expecting lower reimbursement than managed Medicaid, or?
How is the best way to answer this question? We were very careful when we did our contractual negotiations with the payers in order to evaluate the type of business that may move from a Blue Cross today to a Blue Cross exchange marketplace patient. Yes. I mean, again, there were several unknowns in that process, but we do know how we will get paid. And again, the perspective from the payer community and the federal government was that they wanted providers to go in with Medicaid-like rates. That was the request, was Medicaid-like rates. And they got lots of pushback from the provider community not to offer Medicaid-like rates because, again, we were going to potentially see people who were fully insured today move to this product tomorrow. So those are different pieces that had to be evaluated as we looked at a reimbursement strategy that we wanted to pursue in the process. The other comment I'll make is we've got Blue Cross, who serves one type of insured, and I would probably argue that the Community Health Choice, which today is a Medicaid plan, has greater marketability among many of the uninsureds, potentially, at least CHIP family members within the Galveston County area than Blue Cross does. So strategy working with Community Health Choice looked a little bit different than our strategy working with Blue Cross. Thinking that potentially Community Health Choice might be going after the parents of their already CHIP membership. And then Cigna, quite candidly, is a wild card. We'll see how Cigna performs with this book of business. Other questions? All right, good audience. I'm going to close with this last slide. I think we've all talked about the fact that there's quite a bit of reform that's necessary, both to make healthcare coverage more affordable, but at the same time, we've got some huge opportunities and obstacles to overcome between now and January the 1st. So you've been a good audience. Thank you.
Well, I want to thank you all for attending. You read about this and it's certainly being talked about a lot in the news. And I always find it's better if we can just get sort of a factual foundation for those discussions so we better understand what the issues are and also how we're prepared at UTMB to respond to those issues. I know I heard a number of things that I think are very reassuring from, even though the exchanges are down, Nancy and the folks that work in financial counseling have still been able to provide answers to many of our patients, as well as an application process to help them move forward. And that's, I think, great information to have. Also, it was very heartwarming for me to hear about, as we negotiated our managed care contracts, we heard that Becky was thinking, and her team was thinking about the fact that people might move from current insurance to the exchange insurance. And so as we developed our strategy for negotiating with those carriers, we were able to do that in a thoughtful way and potentially position ourselves well. The third thing that I heard that I thought was very helpful was the fact I kept thinking, well, we're not hearing a lot about cancellations of policies in Texas. But I didn't realize that several years ago there had been some changes that actually for Texans and for our insurance would help us be a little more immune to that happening. So I really appreciate the fact that Becky took time to educate us. I hope you leave feeling as if you have a little more information to be able to have good, well-founded discussions with others about how we are participating and how we have essentially, I think, planned as well as we could to be competitive in this new marketplace. So I appreciate your attendance. It's been filmed, so people will have an opportunity to look at this on their computer as they're eating their own sandwiches, maybe at other shifts and so forth. I know a number of people after mine said that they weren't able to come, but they had actually seen it on the computer, and after I did a spot sort of quiz, I was reassured they actually had looked at it. But we will do another one, the one that's coming up in February. Deb McGrew has graciously agreed to do around patient and family-centered care, and a lot of good information of what's happening now in the industry around that. So if you have ideas for topics you're hearing about, I was thinking, population health management, what's that? What are we doing? If you have other topics you would be interested in hearing about in these sessions, just drop me an email, and I want to make sure that we're addressing the things that will help you be better able as a member of our UTMB community to be able to talk to others about, not only in the workplace but outside of the workplace. So thank you again for coming, and you can all brave the cold and go back to work.